Thank you so much. I feel slightly overwhelmed. I've never had an honour this great, and it's thanks to Dr. Mohan and Anjana and to all of you. I'm very proud and humbled to be here, so thank you. As was said in that introduction, I'm a clinical diabetologist. I only do diabetes. And I sometimes joke that I only do type 1 diabetes because I can only spell one drug, which is insulin. And that used to be true, but now there's lots more drugs, and I now need to learn some new names again after Professor A.Nauck's tour. So diabetes gets more and more complicated, I think, for all of us to manage and to support self-management of people living with diabetes. And that's one of the great challenges, and that's why it's such an exciting field to work in. We don't just have one drug, we have many drugs. We don't just have one technology, we have many technologies. And the unique thing about diabetes is that we all work in a multidisciplinary team, and none of us can do anything for our patients on our own. So it's a real privilege to be here with all of you and to hopefully talk you through some digital interventions for prevention and management of type 2 diabetes. So you're very welcome to take photos of the presentation, and I'm very happy to share my slides afterwards as well if you would like. I do have some declarations of interest, and I'll give you 2 seconds to read those. So what I will talk through in the next half an hour or so is listed here. I'll try to get to grips with what is digital. It's an often used word, and sometimes I think it's important to be clear about what we mean when we talk about digital interventions. I'll talk about why diabetes is special and what the digital opportunities are for diabetes, and I'll concentrate really on smartphone use and text message and app usage for prevention and management. I'll then talk a little bit about glucose monitoring, both intermittent and continuous glucose monitoring, and no talk on digital is complete without talking briefly about artificial intelligence and the impact it's going to have on all of us and hopefully all of our patients in the near future, and then I'll summarise for you. But let's start with the slide that has the most words on. I promise you, no other slide has this many words on it. But I thought we should go to the source and try to understand what digital means. So if you read the WHO Global Strategy on Digital Health for the next 5 years, or actually for the last 5 years, there should be a new strategy coming out next year. It's long, but fundamentally what it's saying is that digital health can be anything. It's any digital technology, it's anything on smart devices or connected equipment, and it includes the Internet of Things, artificial intelligence, and even robotics. So it's an incredibly wide field, and if I really wanted to talk about that, I think we'd all be here until midnight, and I'm afraid you'd all be slightly bored by me. So we're only going to focus on some of those connected and digital solutions, and I'm going to focus in particular on research that's happened here in Chennai. So why type 2 diabetes? What is the importance of doing this within type 2 diabetes, and why is it such a fertile opportunity for digital health? Well, I think we're probably all slightly biased on this, but from my point of view, diabetes is the archetypal long-term multi-system condition. I cannot think of another long-term condition that affects any human that requires as much ongoing self-management and touches as many other organ systems. And that's been very true over the last 2 days, where we've had fantastic talks from hepatologists and cardiologists and drug discovery, and you will all have different interests within diabetes. So I think it's a really fertile and a fantastic opportunity for digital to sit within that long-term condition requiring self-management. And digital is flexible, so it can be based in point of care, in the clinic, and remotely in the person's home, and it can be involved in prevention and management and complication treatment for type 2 diabetes. So it's an incredible opportunity, and digital can fit into all of those spaces in different creative and novel ways, and that's hugely exciting, and it's a very exciting place to be at the moment because there are so many opportunities. But let's start with the one thing that's in everybody in this room's pocket. Put your hands up if you don't have a smartphone on you. There we go. So we all have a medical device in our pocket at all times. And that's a huge opportunity. Everyone has a mobile phone, everyone is always available, and your mobile phone is almost always available because it is in your pocket. You can use a mobile phone, a smartphone, for multiple modalities of communication. So you can call people, you can message people. I heard earlier today that WhatsApp is the most prevalent form of communication within India. Is that correct? Ahead of face-to-face, which is extraordinary. I suspect it's true in the UK too. But that tells you the power of communication and using messaging. You can use multimedia, so you can use sounds and video and any other media you can think of, and you can deliver push notifications, which can be urgent, and you can deliver alerts for glucose extremes that are high and low. You can use smartphones locally, and you can use them in the cloud to pull data in, to push data out, and to see the world around you. So they're an incredible opportunity and hugely powerful. So let's start with the simplest communication. Let's start with text messaging. It's one of the first things. The very first mobile phone I had was 1997, and text messages were really exciting. So it's incredibly simple. It's universally available on every smartphone. It's often free and can be accessed anytime, and importantly, multiple times. If you want to go back and read a text message, as long as you haven't deleted it, or the person doesn't want you to see it again, you can reread that text message. So it's a way to have readily available information delivered once and readable multiple times, and it doesn't require an app for download. So everyone can receive and give a text message the moment they open their first mobile phone. And on the right there is an example of a very simple text message conversation relating to diabetes. So several years ago now, back in around 2013, we collaborated, Imperial College London collaborated with investigators here in Chennai in a text message study aiming to prevent progression to type 2 diabetes. The study recruited 537 working men in Chennai, and all of them had impaired glucose tolerance on an oral glucose tolerance test. Participants were randomized to a text message intervention or to be in a control group, and the text message intervention was motivational text messages delivered several times per week, and the content was adapted alongside a model of behavior change. So if we want to change people's behavior, what we have to do is embed that in a validated model of behavior change supported by an evidence base. So we used what's called the trans-theoretical model, which is summarized on the right. So anytime any of us make a change in our diet, which we might all do after some of the talks earlier today, we go through 5 stages. So we start at pre-contemplation, where we're not really thinking about it at all. We then move to contemplation, where we're starting to think, hey, maybe I should cut out some of my carbohydrate. We then go into a preparation stage where we've decided that we're going to do it and are thinking about how to move into that. We then take action, which is doing the thing that we have decided to do. And following action, the most important stage is maintenance, and maintenance is sustained behavior change. Now, importantly, the arrows on this go down because hopefully you follow that trail, but of course people can unfortunately go back up, and a classic example of that is smoking cessation. So people give up smoking, they're in maintenance, but they then slip back because something stressful happens, someone offers them a cigarette, so people can go up and down through that. And there's a very good questionnaire to discover which stage of the trans-theoretical model people sit at. So the primary outcome from this study was progression from impaired glucose tolerance to incident type 2 diabetes. This is some examples of the text messages that we sent by the stages of the trans-theoretical model. I'll give you 2 seconds to have a look through them, but on the right are the dietary advice text messages, and on the left are the physical activity text messages. And you can see that they start off in pre-contemplation, just giving information and hopefully encouraging people to start to think what that information means for them. And it goes through into maintenance, where it's really just saying, well done, keep going, have a healthy week, you're great. So using that, we had a really important result. So we showed that in those men who were randomized to the intervention, there was a 9% reduction in the incidence of type 2 diabetes with the text messaging intervention, and that was over a follow-up period of 2 years. So this is a very pragmatic, cheap and scalable intervention. You could send text messages to one person, or you can send text messages to 150,000 people. And the impact, therefore, is scaled up hugely, but cost and resources are not necessarily much greater. And in this study, you would need to treat 11 men to prevent 1 case of type 2 diabetes. So this is potentially not only clinically effective, but it's also cost effective. There was then a 5-year follow-up of the same participants, and there was no intervention at all between those 2 and 5 years. There was no contact and no intervention. And at the 5-year follow-up, the effect size was maintained, and in fact, at that point, it was slightly higher. You only needed to treat 9 men over 5 years to prevent 1 case of type 2 diabetes. So this pragmatic, scalable, cost-effective, and clinically effective intervention is very straightforward to prevent type 2 diabetes in men. So to follow that up, we collaborated again with the same investigators here in Chennai, and we had an MRC ICMR award to conduct a larger study in Chennai and in London. And this time we recruited men and women, and we defined our inclusion criteria not by impaired glucose tolerance, but by both categories of non-diabetic hyperglycemia assessed by HbA1c criteria. And there are lots of issues with that, which would be a whole separate talk in itself. But that was the decision that was taken at the time, and we delivered exactly the same text message intervention by the trans-theoretical model of behaviour change. As you can see on the right, this unfortunately was a negative study. So in both the UK and in India, there was no reduction in the progression to type 2 diabetes, and the only signal really was that it appeared that women, in contrast to our initial study, which was only in men, if you remember, the women do have a small reduction in the progression to type 2 diabetes, but this was a slightly disappointing result. But the only other thing that I would say about this is you can see that the UK effect size was essentially 0. I think the UK recipient of text messages were much less inclined to read them and certainly take notice of them than the group in India. So we haven't followed those data up further, but I think it's important to remember that even if in this study that reduction in progression to type 2 diabetes in India wasn't statistically significant, at a very large population level, it may be clinically important, and text messages remain a potential way to deliver a pragmatic, scalable, cost-effective intervention for cardiometabolic health. But apps are much more exciting, and the majority of us now spend our time on apps rather than on text messages. Apps give you increased creativity and flexibility, and they combine lots of modalities of behavior change. So not just messaging, but multimedia, gamification, data collection, reporting, aggregation. We can reflect data back to people in ways that are more accessible. And they obviously are something that people enjoy. We all download lots of apps and we all use them all day. But they do require a download and active data, and of course some of them may cost money, so there are some potential downsides to apps. I've been very privileged and honoured to work with the Madras Diabetes Research Foundation as part of National Institutes for Health Research Global Health Research Unit to co-develop apps that have been co-developed here in India, and these are 2 of them that were developed as part of that Global Health Research Unit. They're called SweetHack and Buddy. So SweetHack is a similar game to Candy Crush, which I suspect lots of you will have played. But it's not just Candy Crush, because once you complete a level, you then get some education, you get some prompts and further tips on how to live with impaired glucose regulation, with the aim, again, of trying to improve cardiometabolic health with a digital intervention. Bud.D is different. Bud.D is a chatbot, so you can ask Bud.D questions, and Bud.D will give you lots of curated, appropriately quality assured and quality controlled information in a hope that will enable people, again, to follow that trans-theoretical model of behaviour change, to go to contemplation, preparation, and hopefully into action. The team here, led by Anjana, have led a pilot randomised controlled trial several years ago, which was unfortunately interrupted by COVID. But this was undertaken in an urban setting here in Chennai and in a rural setting just outside in Tamil Nadu. Participants had an IDRS risk score of greater than or equal to 30, so were at high risk of progression to type 2 diabetes, or they had a fasting glucose of 126 or greater, but we did not recruit people with type 2 diabetes. People were randomized to either use one of the two novel apps, SweetHack or Bud.D, developed here, or to use available commercial apps, HealthifyMe or Google Fit. And you can see the results on the right for BMI and waist circumference. So the control group is on the far right, and you can see that BMI slightly increased, but for all four apps, there was an equivalent reduction in BMI. The greatest would appear to be with HealthifyMe, but the error bars are reasonably large. And very pleasingly, the two new apps developed here showed a reduction in BMI. Similar reductions were seen in men and women for waist circumference, with no change in the control group. And when you look at systolic and diastolic blood pressure, again, there were reductions in those and reductions in fasting blood sugar. So this was fantastic news, really encouraging. As I said, this did get interrupted by COVID, and one of the things that the team here had to do as part of that randomized controlled trial was deliver engagement phone calls. These were infrequent, but were done equally across all of the groups. So novel apps and available apps were all impactful in addressing cardiometabolic risk in an urban and a rural population at high risk of progression to type 2 diabetes in India. So following on from these, I would encourage you all to go downstairs after this and before the gala dinner and have a look at poster 31. Because poster 31 is work from that same pilot study and is really interesting. So as part of the pilot study, at the point of recruitment, the research team said one question to every participant: how willing are you to use a smartphone app for health? And these are the results. And it's really interesting because men were 2 times more willing than women. Younger age group, as you might expect, were 3 times more likely to use an app. Those at higher risk by the Indian Diabetes Risk Score were more likely to use it, as were those with a family history. Those who did more physical activity were more likely to use an app, which again, I think these are all intuitive, but they're really important findings when we're trying to prevent type 2 diabetes progression in people who we might perceive as highest risk, and educated people and people who are fluent in English were also more likely. So when we think about digital health, with many other things, one size does not fit all, and we will have to be slightly targeted about what apps we use for which people to gain an impact. And please do go downstairs and have a look at poster 31. So following on from that pilot study, we're now in the middle of a follow-on effectiveness study using a combined app. You can see a screenshot of it on there on the right that has a personalized avatar. It has combined the two apps, so this is SweetHack and Bud.D together, and you can see them there, so you can click on one or the other. And it's been much more gamified now, so the participants in the study get a position on a leaderboard and they get badges, and this gives them additional gamification and encouragement to participate in the app and to make the changes suggested. It also gives a direct step count so people can see their own physical activity within the app. It's a larger powered study, still undertaken and led here, but also a centre in Delhi and rurally in Tamil Nadu, and I'm incredibly impressed that it's fully recruited now over 3,000 participants. So the data from that, I think, will be towards the end of next year, and I'm really excited to see that. So let's talk a little bit now about digital health in glucose monitoring. There was a session earlier today that was fantastic with Jyoti Dev and Dr. Ranjit talking about technologies and how they can be used in particular to guide behaviour change in people living with type 2 diabetes. There's huge potential to use digital tools as an adjunct to that glucose information, so we don't just see glucose as single numbers in a line, but we see them as opportunities to make changes, deliver education, and prompt behaviour change. So we can do that both with intermittent glucose monitoring, self-monitored blood glucose, and we can also do it with continuous glucose monitors. These are data from a study led by Dr. Mohan using the My Sugar app, which connects automatically to AccuCheck blood glucose monitors by Bluetooth. So the My Sugar app tracks glucose, gives you insights into what your glucose patterns are, allows you to do meal logging, and gives you activity data, again, all as prompts to move through that behavior change cycle for cardiometabolic health. This was a 3-month real-world assessment in 111 people, 37 of whom were insulin treated, and very impressively, over just a 3-month time, the overall HbA1c fell from a mean of 8.8% to 7.5%, which is highly clinically and statistically significant. And really interestingly, if you look at the graph on the left that separates out the insulin-treated group and the non-insulin treated group, the insulin-treated group started with an HbA1c of 9.3%, so well above target, and landed at 7.6, so a really significant reduction. And the non-insulin group had a smaller reduction, but had a lower HbA1c at baseline. And the greatest reductions in this study were seen in the younger participants and the people who were self-monitoring more than or equal to 6 times per week. So this is, again, relatively easily accessible, easy to use, intuitive, it looks nice, and it has a really important clinical effect over just 3 months. So what about continuous glucose monitoring? So this is data from a study that was undertaken by Dexcom, who make the G6 and G7 continuous glucose sensors, and this is using continuous glucose data as a tool for behavior change without any real adjunctive education. So I think one of the things about seeing your continuous glucose data is that if you see those higher glucose values, if you hear those alerts or alarms for higher extremes or for rapidly rising glucose, it can prompt you into making a behavior change. We have to be very careful because it can also be burdensome, irritating, and get in the way. But if used correctly, continuous glucose monitoring alone may well be a good tool for behavior change. I think it's really striking that we've had continuous glucose sensors now for nearly 25 years, and no one has done a large, well-constructed behavior change study with CGM. And that seems to me to be a very obvious thing to do in people, for example, with pre-diabetes. But this is adults with type 2 diabetes. It's 150 of them were recruited, and they are all users of basal insulin. They use the Dexcom G6 sensor for around 10 months, and these are the results. So you can see this is separated out into participants who had suboptimal time in range, so glucose generally above target at baseline, and those who had optimal time in range at baseline on the right. And you can see that in both groups, there was a change in time in range. On the left, the suboptimal group had a really significant large increase in their time in range of 13%. 1% time in range is about 14 to 15 minutes. So that's a really meaningful increase of 3¼ hours. Interestingly, the group on the right, the optimal time in range, looked like their glycemia might have got slightly worse. They spent 6% less per day, so an hour and a half less per day in target. But a lot of that comes actually from the column below, which is the hypoglycemia. So they squeezed in their distribution of glucose by getting rid of hypoglycemia. HbA1c improved in both groups, both suboptimal and the optimal, but really interestingly, despite an improvement in HbA1c in people with type 2 diabetes who are insulin treated, they lost weight. Now, in my view, most interventions that improve glycemia in people with insulin-treated type 2 diabetes are at risk of an increase in weight, but with continuous glucose monitoring enabling you to see those insights, avoid hypoglycemia and additional calories to rescue from hypoglycemia, there was a meaningful weight loss of nearly 5% in both groups. And both groups started with a very high BMI, and there's obviously still work to do for both groups, but I think that's a very important finding. So what about AI? AI is coming at us if we like it or not, and unbeknownst to us, it's being part of our lives every day. Every time we do a Google search, every time we look for something online shopping, every time we have an ad that pops up on our laptop or on our phone, AI has been involved in that somehow. Things like train timetables, aeroplanes, everything that we touch now has some AI within it or around it that is impacting on our lives. And the really lovely thing about that is most of the time we don't notice. So it's obviously doing a fantastic job. ChatGPT is a large language model, so it's one of these things that you can speak to and have a human-like conversation with. There are several others available. And I thought for this talk I would ask it a question. So I asked it this question here on the right. I have prediabetes, how do I avoid progressing to type 2 diabetes? And it gave me really good advice. So I haven't shown you all of it, but there's number 1 there and number 2 on the right. There were 9 different categories that included physical activity, stress, sleep, alcohol and smoking. I can't even remember now, there were so many of them. But it's absolutely fantastic. And the thing that I loved about it is that it asked me this question here on the left at the bottom. It then said, would you like me to help you create a personalised meal plan or exercise routine to support this? So I said, yes, please. I think you should always say please and thank you to AI. When it takes over the world, it'll remember you as being a polite one. So always say please and thank you. So I said, yes, please. I haven't done it yet. It wants to know my BMI and my weight and medication and medical history. But it's really interesting that it's able to do this. So it's already able to answer complex questions about lifestyle and diabetes and cardiometabolic risk. What I don't know is how you assess the quality of it. How do you do a randomized controlled trial of something that is a large language model when the inputs to that change every day? So ChatGPT will give you answers based on what it can find, and every day it can find new things. So you have to be very discreet about what you put into your intervention. It needs very clear implementation too. This is great, but it's just a list on a phone. I need to translate that into an action if I want to do something meaningful. So it needs an implementation piece to be an effective intervention. And of course, the other thing that we have really importantly to deal with is a digital divide. So a significant number of people, certainly in the UK, have significant socioeconomic deprivation and are unable to access a smartphone or the internet. So it's all very well us saying, well, everyone can use ChatGPT, but actually those people at highest risk with socioeconomic deprivation are not able to do that, and it would not be a priority necessarily for them to implement what ChatGPT says. So we have to be cautious about how we do so, not just in an equitable way, but in a safe and effective way. And finally, this too was mentioned earlier in the technology talk, but I think it's a really fascinating use of artificial intelligence. And this is actually the first true artificial intelligence implementation in a medical device in the sphere of diabetes. All of our hybrid closed-loop systems are fixed control algorithms with run-to-run adaptation, but this is a true AI. So this is the Roche Accu-Check continuous glucose monitoring system called SmartGuard, and it uses 3 different AI algorithms in real time to give you glucose prediction. So the first glucose prediction is 30 minutes, and you can see that in the top graph on the left. It will then give you a 2-hour glucose forecast. So if you're going to get in the car and drive for 2 hours, if you're going to the cinema and want to watch a film and you don't want an alert to go off, you can do something about the next 2 hours that enables your glucose to be stable in your desired range. And when you go to bed at night, it'll give you a nighttime low predict. So one of the biggest barriers to optimal glucose in type 1 and type 2 diabetes is fear of hypoglycemia, and in particular fear of nocturnal hypoglycemia. So if we're able to give people a risk of nocturnal hypoglycemia based on a complex AI algorithm, then at bedtime you're able to do something about that, and you're able to prevent that nocturnal hypoglycemia. So this is really exciting. The only thing I would say about it, as a clinical scientist and as someone who's curious, as you all are, is that this needs clinical data. It sounds great, but we don't know that this is more effective or less effective than any other way of managing glucose with continuous glucose monitoring. I think we would all feel that intuitively it should be helpful for self-management, but we need to see some robust clinical data for that. So in the last minute, I'll just summarize where we are. I think, as I've said, we're living through an explosion of digital technologies, which we should all embrace and be hugely excited by. The application to health, not just diabetes, but all health, is enormous, has enormous potential, and I think personally the next 10 years we'll see changes in the way that we manage some long-term conditions. As I've shown you, text messages are pragmatic, scalable and cheap, and they may sustainably prevent progression to type 2 diabetes in some populations. Smartphone apps can be beneficial for cardiometabolic outcomes, as we've shown in our pilot study, with minimal additional input, and a more robust evidence base is coming. Younger men with higher education and a higher baseline risk of type 2 diabetes are most willing to use apps for prevention of cardiometabolic disease, and glucose monitoring technologies, both intermittent self-monitored blood glucose and continuous glucose monitoring, can be enablers for behaviour change, again, without additional input. And finally, AI tools will further transform type 2 diabetes prevention and treatment within the next few years. And I just want to leave you with one final thought. I love technologies. I think they're absolutely incredible and they have huge potential. But I can't tell you one technology that will ever replace us as clinicians, and it won't replace face-to-face education, support, compassion, empathy, prescription, explanation, and all of the wonderful things that we all do day to day in diabetes. I sometimes get criticised for being critical about technologies, but technologies are only ever an adjunct to support and education. They can be hugely powerful, but that support, education, and clinical ability comes first, and technologies will then take us all those final extra miles. Thank you very much.